Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. So good to see you two.
Hi there.
Hello.
All right, before we jump into the mailbag, we want to clear up a couple of things. Well, not clear up, but just talk about a couple of things. The first being, we are so grateful that so many of you have joined our Patreon community. If you're not familiar with Patreon, it's an incremental giving platform where you can help fund the shows that you love. And there are some cool incentives that we've come up with, including a monthly Zoom call with Dr. Cooper. So thank you so much to those of you who've joined, and keep that going, because it's going to be super fun to gather in the Patreon community. And we also have to clear up one thing. Mailbag is not going behind the paywall. So it is going to stay open and free, and we are getting hundreds and hundreds of emails from you guys, which we love, and we'll get to as many of those as we can in these mailbag episodes. So thank you for that. And if you have a question for us, just go to the Fat Science website, fatsciencepodcast.com, and you can get all the information there, including how to listen to the shows and how to share the shows. All right, so you guys ready?
Ready.
Ready to go.
Let's jump in to the mailbag, Andrea.
I have the first one from Jen, and she is searching for a doctor who approaches metabolic dysfunction with the depth and curiosity that Dr. Cooper demonstrates. Her PCP prescribes GLP-1s, but only gives her a few minutes, like a lot, and runs only basic labs. So she wonders what tests she should request and what qualifies, what qualities define a good metabolic doctor. So many people are always asking me, and I try too. So this is what she said. She said, my PCP is nice, but she only spends 5 to 10 minutes with me and doesn't dig deeper than basic CBC panels. When I listen to the podcast, I hear a level of curiosity and thoroughness that I'm not getting. I've struggled with my weight my entire life, every diet, over exercising, all of it. And I want a doctor who actually looks for the root cause. If I need to advocate for myself, what questions and tests should I request so I'm not missing something? Oh, this is going to be a good answer.
What a great question, Dr.
Yeah,
Cooper.
this is good, because everybody is always asking me this, and I would love a concise thing that I could point to people.
Well, Jen, thanks so much for the message. It is hard to find doctors in any specialty area right now who have the time and the curiosity, and the wherewithal to look deeper into people's problems. So whether it's metabolic dysfunction or anything else, we're kind of hearing this about our medical system right now. And as you said, you spend 5 to 10 minutes, in an office visit, which is really tough to kind of discuss anything beyond the surface information. But one thing that might be good too is sometimes I find that, this is just an idea throwing out there, but sometimes I find that nurse practitioners and physician assistants have more time. I know that sounds crazy that we would want to go to someone besides a doctor, but the way the healthcare system is, the doctors are like really overworked, and there's not enough doctors, especially in primary care. So they are reduced to, these 10-minute visits, which are really tough, while the nurse practitioner and the physician assistant often will get more time. So that's one idea, is to see if you can find someone that could be more of an ally there, and spend more time with you. But in general, just to kind of prod them about testing, I think the most important tests really have to do with insulin levels. So it's glucose and insulin. So you say CBC panel, you probably mean also there's this panel called the Comprehensive Metabolic Panel, which is really misnamed because it's everything but comprehensive.
But that's what they call it when it's like on your insurance.
It's what's called, and it's called metabolic when it really doesn't look much at your metabolism. It contains just like your organ function parameters, like your liver function, your kidney function, your protein levels, which are part of kind of our liver health too. And it's not, it's really not giving you a whole lot of insight into the metabolism, but it's a good panel to look at for your general health. Same thing with the CBC. So neither of those really tell you a whole lot about your metabolism, other than maybe if your liver enzymes are elevated, maybe that means something that has to do with fatty liver problems. But I think in general, adding, of course, the HbA1c, which is the 3-month average glucose test, that's important. And the fasting insulin levels along with the glucose, that's important. And just so patients know, or people out there know that aren't doctors, there's something called the GIR, glucose-insulin ratio. If you calculate that based on your fasting glucose and insulin, it kind of really helps see where you stand. So you take the glucose, divide it by the insulin. And if that number is 7 or less, that is the GIR, glucose insulin ratio of 7 or less. That really suggests insulin resistance. So that's a good thing to at least rule in or rule out. If that ratio is greater than 15, it suggests what we call the selfish brain, where the brain is worried that you're going to starve and run out of fuel and run out of carbohydrates. It's almost like the brain doesn't tolerate fasting very well because this is done on a fasting test. So that would mean you better make sure your diet has enough carbs and complex carbs and things like that, and that you're not having low blood sugar reactions. So if it's the insulin resistance where the GIR is 7 or less, then that could be a conversation about, well, am I a candidate for metformin or a GLP-1? Like what is really the cause of this? And so that's just some basic. There's also something called a FIB-4 score, and that can be calculated from those basic tests that you're describing. That tells your risk for what's called MASH, metabolic dysfunction associated steatotic hepatitis, or it's really like an inflammation of the liver that has to do with scarring from fatty liver disease. So similar to MASL D, which is just the fat in the liver, but this would be a sign that it might be more serious. So the FIB-4 score, if that especially is 1.3 or higher, that's concerning too. So that falls into the metabolic thing. If your blood pressure is elevated, that falls into metabolic syndrome. So there's so many markers to consider. Then when it comes to your cholesterol panel, if your triglycerides are high, that's also a sign of metabolic dysfunction. So getting that whole picture of your metabolism by looking at just some basic tests, these are all basic tests. So I would start there to see if you can get more information, and then maybe it would spark your providers thinking that maybe you need to be on a different medication or some other suggestions that they have for how you're going to really improve your metabolic health.
Dr. Cooper, I want to ask maybe a tricky question here. In your mind as a healthcare provider, if that physician is spending 5 to 10 minutes with you, would it make sense to have a discussion that sounds something like, hey, I don't feel like I'm getting the attention that I deserve from you? Or do you think that you should just go find a different provider because for whatever reason, that physician is either being, watched by the accountants or just simply doesn't have the interest in treating metabolic syndrome? What would be your best advice when it comes to evaluating, having that discussion with the provider?
I mean, I think it should definitely say, is there any way we can have more time to look into these things or discuss these things? But the issue is, honestly, our healthcare system has built into it that it's run by non-medical people, in most cases, run by insurance associated huge conglomerates that are looking at profit-driven markers. And they are using the doctor to rank up or whatever you call it, rack up. I'm not good at those. Rack up their income because they can charge a certain level for a certain kind of visit. And the visit durations tend to be really short. And so, but it's just the way that everything's scheduled. Those doctors get fired if they don't keep up that schedule. So that's when you go to a center where it's run by especially some of those insurance companies. And, people don't even realize that these big companies like Optum and stuff, that's insurance companies getting involved or some form of insurance or management, medical, financial management that's involved in all that. And so some of those bigger companies that are running these big clinics in the US, that's kind of why the visits are so short. They do allow longer time sometimes with the other providers, as I said, the nurse practitioners and the physician assistants, just because they cost less to hire those people. So, and it's not that they don't do as good a job. I mean, I think for something like this, the most important thing is somebody who cares, not necessarily their degrees. I know that sounds crazy, but it really is somebody who cares and will look into things, because you have to keep in mind the nurse practitioners and physician assistants report to the doctors. So where there's a question, they will go and ask for more support, more help, more troubleshooting with the provider, but they may be able to spend more time with you. But then I think the other alternative is getting outside of that type of system and going to someone who has their own practice, because the doctors that have their own practice, they're not operating that way. They're not on the 5 to 10 minute visit. They're in there having their own practice because they really care. They don't want to work in that type of a system. They don't feel like they're making a difference enough. So small group practices are good. Or doctors with their own practice are good. And sometimes those are just still going to be covered by your insurance, but then it gets into the cost, because some of those practices, we are in a system now where it's not fair, but in order to get access to that kind of higher quality care, people are having to pay like monthly subscription fees. So this is, called direct primary care, where the patient is billed a monthly fee, and then that includes, it's fairly all inclusive. So if you need the provider or not, you have the coverage. But to me, I've never kind of opted for that in my own practice so far, just because to me, it doesn't seem right. I mean, it seems like if you're paying for a service, that service should already be of that quality. You shouldn't have to pay an extra fee just to be a member of a practice so
Right.
that you
That's
could
what they call
access their.
concierge medicine.
Yes, and so that's the tough part. But I would say, as Mark, as you pointed out, why not just have a conversation and find out, is there a way in this practice that I can get more out of my care rather than just a 5 minute check my, CBC type of thing when I have this serious problem, or do I need to look elsewhere? Or is there a different provider in this practice that could spend more time with
Yeah, they
me?
might send you to a specialist.
But then, the specialist too, it's the same. You run into the same thing. If they send you to a
Sure.
specialist, maybe that would help. But, but again, the specialists are focused in on a very small piece of you. And so the ideal, I've been online a lot with this lately of how much I support primary care practices doing this metabolic work. The reason is they are more tuned into your overall
Yeah.
full entire medical picture. And since metabolism is so widespread and affects every different organ system in our body, you can imagine if you isolate that to a specialist, they may miss a lot of things that are connected,
True.
a lot of those connections. And so they may be focused in on, unfortunately, your BMI. Um,
Yeah.
and as we know, focusing on that is not necessarily where the whole issues are with metabolism. So they
Yeah.
may not go as thorough as you think they will go. But still, as you said, Andrea, maybe that is helpful at least to get a second look at things.
Yeah.
So I'm sorry I don't have a better.
Sometimes it's your only option if you're in a group care
Yes.
situation. It
Yeah.
may be your only option that you have, like for your insurance coverage.
Yeah, I think finding someone who cares is the big thing. Um, and that's the thing. Someone who really
Yeah.
cares and is kind of enthused about their job, working in a place where they don't feel that pressure to just like, the stress of just get through the visit in 5 to 10 minutes.
Yeah. But that's a really good insight from Jen. And
Yes.
keep fighting for yourself, Jen. There's only one you. And just demand the care that you deserve. All right, let's move on. Next question is from Andrea from Redmond, Washington. She's tried nearly every diet over 20 years and always felt hungry despite being very active. After starting Zepbound, she experienced weight loss, complete elimination of food noise, improved sleep apnea, reduced inflammation, better emotional regulation. She wants to know if GLP-1s and GIP meds have documented benefits beyond weight loss. So, in her words, she says, I've dieted for 20 years vegetarian, keto, vegan, low carb, high carb, gluten free, yet I've always been hungry. I work out, constantly lift, run, hike, garden, but I've always felt like my hunger was louder than my effort. But after starting Zepbound, she says the food noise vanished. My sleep apnea improved overnight. Inflammation disappeared. She hasn't felt pain in weeks. Mentally, I feel calmer and more emotionally level than I have in years. So she wants to know, are these known effects of the GLP-1, GIP combinations or just anecdotal? Dr. Cooper, this is a great question.
It is a great question, Andrea. This is definitely these observations you're making are definitely associated with benefits that these medications have shown. And so things like the inflammation, they have been shown to reduce inflammation. When you think about it, our body fat releases a lot of inflammatory chemicals. They're called adipocytokines. And some of them, there's one that's anti-inflammatory, which is called adiponectin, but the rest of them are pretty much pro-inflammatory. And so anything we do that lets us start accessing that body fat and reducing that tends to reduce the levels of all of those inflammatory cytokines too. So it's been shown, and even in our patient population, markers for inflammation like HSCRP, that's one of the inflammation markers, SED rate, we'll see those numbers start really coming down once people are making progress on whatever the medication is for their metabolic health. Anything that's improving their metabolic health, you'll see that, whether it's the GLP-1s or other pharmacology. So I think that's wonderful. And then the hunger, we talked a lot about why this quote food noise changes, and it has to do with the fact that Zepbound represents two different hormones our body makes, GIP and GLP-1, and those are beneficial, what we call security signals that tell the brain we have enough food supply. So people with high body weight are found to have dysfunction with their incretin hormones, which are the gut hormones like GIP and GLP-1, where either they're not being produced the way they're supposed to when you eat a meal, or the signal's not being received accurately in the brain. So that's why taking the medication provides those signals that we need to change our satiety cues. And so that's what you're noticing is that when you eat food now, it just, registers in the brain and you're done. And then you don't even think about it until the signals come back saying, oh, we need a little more food, like a few hours later for a meal. So one of the problems is that if people aren't used to that, it can wipe out their appetite altogether. So you just have to make sure, we always talk about the mechanical eating, whether you're hungry or not, get on that schedule, eat consistently, fuel your body, just to avoid triggering back some of those dysfunctional famine signals that say we're starving, we're starving. So anyway, that's one idea. When it comes to sleep apnea, Zepbound has an FDA indication for sleep apnea because it is shown to reduce sleep apnea. And so in fact, that does help with prescription coverage sometimes if you've been tested and you have to have moderate sleep apnea, which is that AHI score of 15 or higher. So I think that, these things we're going to find more and more because the reason is that these are beneficial hormones, as I said, that we naturally produce from our gut. And when we replace those in people who had inadequate levels or inadequate sensing of those hormones, a lot of positive things happen in the body because they're very beneficial from a health standpoint. In our peripheral system, they trigger all kinds of improvements throughout our body, kidneys, heart, body fat, bone. You'll see there's an awful lot of signaling that happens within the body. Then, as I said, within the brain, they signal we have enough food supply. So then that helps our body allow fuel to be utilized better by our system. And it works to prevent abnormal energy conservation, which is fat storage. So not only is the appetite changing, but all these other beneficial things are happening.
Wow, that's amazing. All right, Andrea.
So many things that it's good for.
Mm-hmm.
Oh, yeah.
Yeah, it's really been proven. So the next question, is from Kate, and she's several years into recovery from restrictive eating, and she follows mechanical eating, which we've talked about before. But even small amounts of fruit, like one kiwi, causes a large glucose spike followed by a crash. And she wants help understanding why this happens and how to safely include more carbs in her diet. And this is what she said. I've come a long way in recovery. I follow mechanical eating with all food groups, which is really good. But even a tiny carb, like a single kiwi, spikes my glucose to 150, and then I crash quickly afterwards. I want to eat more fruit and carbs like you recommend, but I feel terrified because the spikes don't seem to be improving. What could be going on in my body that makes these small amounts affect me so dramatically?
Well, that is a really good question. And, in my mind, I'm thinking, several things could be going on, Kate. So,
Science.
yeah. So, I don't want to sound like giving a lecture, medical lectures when
It's
I
a
answer
science.
these. But this is actually a common presentation you'll see with people who went a long time with like restricting food intake, then they're trying to get normal again. When I wrote my book, and I do have to revise it, and I'm trying to revise it, but I've been so busy, I haven't been able to get it finished. I named it, I called it the metabolic storm, and the reason is because like what Kate's describing is sort of features of that metabolic storm that happens after long periods of restriction, and then you're trying to just be normal. And unfortunately, it's really because of that pendulum swinging into the restriction. When you're going back to normal, it's very common that there'll be real dysfunction in the way that insulin and glucose interact together in your body, that the calibration is way off. And so, because when you're in a real restrictive phase, the insulin is very suppressed, and that's not normal either. That's because the brain is worried that it will run out of fuel. So it suppresses these insulin outputs in order to basically starve the rest of the body of the fuel so that it has enough fuel to keep going. Then, once the brain is more secure, it stops doing that, and the insulin bounces back, but in an exaggerated way. So then it shoots way up, which causes these terrible low blood sugar reactions and a lot of instability in the metabolic system. So there is a way to get through it. But the first thing is that when the blood sugar goes to 150 after eating, that's not really spiking that much. That's considered normal. So it depends on the timing, of course, how soon after eating that was. But that would be normal within that early part of right after you eat. So it isn't the blood sugar that's causing the problem typically. It's usually more the insulin. And so what I urge Kate to do is have her doctor ask her doctor if she could have a test where she eats that kiwi and they measure before eating it, then at 30 minutes and at 60 minutes, the glucose and the insulin at those 3 time points. And then you'll be able to see what's really going on. When we talked about earlier in one other earlier question about the fasting glucose and insulin ratios, when we're looking at after eating, it flips to the opposite. So after eating, instead of looking at the glucose divided by the insulin, we flip it around and it's the insulin divided by the glucose. And we want every time point after eating, we want that to be that the insulin is less than 50% of the glucose. That would be where it's perfectly matched. It's in sync with the glucose, the insulin production. So what you might see is that at 30 minutes, your insulin's way above the 50% mark. And that's why your blood sugar's dropping. So if that were the case, there are things that you can do to calm down that insulin, prevent it from spiking. But in the meantime, the other thing I suggest, you may have already tried this, is it's not good to, when you're sensitive like that, it's not good to eat foods without it being a balanced meal or snack, meaning you need something with that kiwi, to help kind of tone down the digestive system, and when food's in your mouth, tone down the signals so that maybe you mix that kiwi with like yogurt or something with something with protein and fat, basically. So you need protein and fat with that kiwi, maybe a handful of nuts and something, ideally have it be part of a meal. So not, or, especially if you're sensitive to a specific food, incorporate it more with a meal that's balanced instead of by itself. And and then I think it is the kind of thing that needs to be treated if it is due to the insulin spikes, because it just keeps happening, repeatedly until you treat it. But once it's treated, it can over time go into like a remission, and then it stops, it calms it down. So it is complicated a bit, but the starting point is the glucose and insulin before eating, 30 minutes and 60 minutes, and just track that. And you could do it either with just the plain kiwi, or, you already know you don't feel good when you do that. So maybe you should do it in a context of a balanced meal and see if you get away with things there, if it looks pretty good. So that's my advice.
Okay. That was Kate from Portland. Thanks for a great question. We're next moving on to a question from Kim, who listens on Spotify. Kim has been on Zepbound since August, has lost 14 pounds, but her cholesterol spiked sharply in recent labs with a family history of high cholesterol. She wants to know if this spike is common when taking Zepbound. So she says, my labs have always reflected my family history of high cholesterol, but this is really a sudden spike and was alarming. I've never seen numbers change this dramatically. I've been on Zepbound for months, losing weight slowly, so the cholesterol increase doesn't make much sense to me. Is it normal to see cholesterol jump when you start Zepbound? Now, side note, Kim also says after gallbladder removal, she suffered daily bile diarrhea for years until it suddenly stopped with the first dose of Zepbound, and she wants to know if that is a known effect. So this is kind of a two-parter, Dr. Cooper.
Yeah, that's great. Well, let me take the second one first. The second part has to do with that bile acid. It's called bile acid malabsorption syndrome, BAMS, we call it. And it happens, it's very common after having your gallbladder removed. And the reason is that usually if we eat any foods containing fat and we have a gallbladder, the gallbladder just squirts out a tiny bit of bile to match the amount of fat that's there to help us digest it. But when we lose our gallbladder, we don't have that reservoir anymore that holds the bile back. So then it just pours out, and it's very irritating. It pours out from our bile ducts, and it's irritating to our intestine, and that triggers a lot of this diarrhea. And it can be just debilitating where people can't even leave the house. And so there are some medications for it. One of the common ones is called cholestyramine, and that's life-changing. But what's interesting is they found, and this is actually what you're observing, Kim, is real. It is documented that other medications in this category have been tested, like liraglutide, which is the second GLP-1 that was developed. Liraglutide has been shown to work for the BAMS better than the cholestyramine. So there's already evidence that GLP-1s do improve this bile acid malabsorption syndrome, which is what's causing the diarrhea after gallbladder surgery. But they haven't done enough research yet to show that the Zepbound does work, but there's definitely reports that it's working really well for that too. And you're living the evidence that it's working because the fact that it improved that much means that for you, it definitely did help. And I think the mechanisms that they're thinking make it work are that it slows the intestinal motility a little bit, the stomach emptying, the intestinal motility, and that way in the intestine, the absorption of nutrients and fats and stuff cause the bile to release slower too. So it's really like perfect drug for treating that. In fact, when I saw the research, because I saw your question, I looked it up because I was wondering about how well these work. When I saw that the liraglutide worked better than the cholestyramine, I'm thinking, geez, this should almost be like the recommended treatment for it. Because whether or not people have a high weight or they don't have a high weight, this problem is just so debilitating that if there's something that works that well, we should probably be using that. And so, yeah. And then for your other question, that's more tricky because I mean, there isn't really any evidence that the Zepbound would cause anything with your cholesterol to go up. But I'm sure if you're noticing it, there is something about this that might be causing it in your body. But what you remember, cholesterol itself, total cholesterol is not very meaningful because it's really just adding up all the different kinds of cholesterol, including the LDL, which is the bad cholesterol, but also the HDL, which in some ways is protective. So I would want to know the whole breakdown of your cholesterol panel, and then also the LDL particle breakdown, and to find out the real risk in there, because it could be that even though you see a higher cholesterol, that overall you're actually at lower risk. You can't really tell from a cholesterol level is what I'm getting at. So there's a test that Quest offers called Cardio IQ, which includes a lipoprotein particle profile. And there's a test that LabCorp offers called the NMR lipoprofile. And so that, either one of those will give you a little bit more detail on your cholesterol panel just to see what the true risk is. Just a cholesterol doesn't really tell you, just because it went up doesn't mean it's higher risk. But there could be something about the Zepbound that is showing that particular marker changing, but I'm not sure how it is related. So I suggest getting a more in-depth test, but as far as we know, Zepbound does not increase cardiovascular risk. In fact, it would be the opposite.
Okay.
That's what I
Thanks.
thought. Our next one is from Erica from Olympia, Washington. And she says her close friend has serotonin syndrome and is afraid to try GLP-1 medication. She's had great success with Zepbound and wants to know whether GLP-1s affect serotonin or pose risks to somebody with serotonin syndrome. And what she said is, my friend has had terrifying episodes with serotonin syndrome, so she's extremely cautious with any new medication. I've been on Zepbound for 13 months and feel better than I have in years. My weight, mood, energy have all stabilized. She's scared GLP-1s might increase serotonin somehow. Is there evidence one way or another? Well, let's also describe what is serotonin syndrome. I don't know what that is.
That's a good question. So, yeah, and it sounds like Erica's friend has had this
Yeah,
serotonin
for a
syndrome,
while.
so she's afraid to take the
Yeah,
GLP-1s, even though Erica's having such good
yeah,
results on her Zepbound.
right.
But
Obviously, Erica is recommending it.
yeah, well, serotonin syndrome is, I can understand why her friend is worried about it because it is really horrible. What it is when serotonin levels build up too high in the nervous system, and it's normally caused by medications, inappropriate combinations of medications or too high of doses of medications. And those medications are typically the mood medications that help us preserve our serotonin so that it lasts longer in our system. So they purposely increase the circulating serotonin levels because serotonin is beneficial for our mood. But it can go too far, and you can end up with overload of serotonin, and that causes a syndrome, which is associated with like terrible symptoms, agitation. You can have muscle rigidity, palpitations. It's really, it can be actually life-threatening if it's severe. So, and usually, as I say, it's going to be that there's SSRI medications, those,
Like what?
they're the serotonin, the common antidepressant mood medications that are in there at very high doses or combination of several that could increase serotonin levels. And so it is something doctors watch out for, and it's rare. It's very rare. But if you've had it, it's terrible. And if it's not picked up quickly and treated and those medications withdrawn, then it can lead to more serious consequences. But the good news is the Zepbound does not at all. increase our serotonin levels or put us at risk for serotonin syndrome. None of the GLP-1s do. Absolutely not. So that's just not a mechanism that you would have to worry about with these medications. There's no association at all of these medications with serotonin syndrome. So I just want to make that clear. They work in totally a different way. So while sometimes they can be beneficial for our mood because serotonin is part of the metabolic pathway, our natural serotonin, and sometimes with certain metabolic glitches, it does affect our serotonin system. And so it may help normalize it a little, but it definitely doesn't do anything to artificially increase the levels or put us at risk for serotonin syndrome.
So she should keep being positive.
That's
Yeah.
great.
Yeah.
All right, our final question is from Jen Lorang, who listens on Spotify. Jen describes the overwhelming surge of GLP-1 microdosing content on TikTok, noting how the algorithm aggressively pushes videos to women who are not medically obese. She worries about how influencers are teaching viewers to get GLP-1s without proper medical oversight. She says, once you see one GLP-1 video on TikTok, suddenly you're seeing hundreds. The algorithm just floods you. Most of the videos targeting women who are only slightly overweight. So they talk about microdosing and show exactly how to get the compounds through telehealth, often by exaggerating symptoms. It felt so persuasive that I even gave my info to one of those influencers before snapping out of it. It scared me how quickly it pulled me in. So, Dr. Cooper, this is so pervasive right now. Microdosing is how some companies are actually advertising GLP-1s.
Yeah, I think by using that terminology, microdosing, it sounds so kind of innocent, sort of like, oh, you're not really doing anything. Don't worry. It can't possibly be harmful. It's just a micro dose. It's like micro lettuce or or like a,
Microgreens.
Microgreens.
Yeah, just have it for lunch. You should just have it with
They're
lunch.
well,
small.
kind of. It kind of takes it into this other realm that's sort of like in the little bit of a supplement or a boost. It's not a real thing. I mean, that's just, I think we've done an episode on this whole scenario and this whole situation. But it is risky, as we've said before, because those micro doses that they're describing, first of all, we don't even know what they're giving people, if it even is what they say it is, because the FDA is not even testing these things. They're so outside of the normal mainstream medical side of things that they're just sneaking in, and we have no idea what they're actually selling people. But even if it was the medication, but at like a fraction of the lowest dose there, that has never been tested in people to see if that's harmful or what that is going to do to your body. And we've described before that these are natural hormones. So anytime you take a hormone, your body will stop producing as much of that hormone because your brain is seeing the level of the hormone, and then through the nervous system regulation, it will send feedback saying, well, we have enough of this hormone or we have more than we were having before, so you should tone down your production. So is that going to train your body to not produce it as well on its own? Now, I'm not worried about that for our patients who have total, diseases where their hormone system is not functioning and they need those medications. Then we have strategies, we have testing, we have FDA trials. We know what they do in those people, and we know that with clinical experience, we can, when people are stabilized, taper them slowly in a slow process, and they seem to balance out fine. But when you give these things to people who don't even have necessarily a qualifying problem, there's no science to show what that does to their system. And we also talked about the fact that these hormones are protein-based, and so our body can form immune reactions against them. And this has all been tested thoroughly for the brand products that are on the market. They had to do that as part of the FDA trials and safety trials. So, that is a concern with this group of medicines, is whether they could trigger our own body to start making antibodies against that hormone. And then that would affect our own hormones too, that it would make antibodies against our own hormones, like an immune reaction. So that's never been tested in any of these off-label, non-branded types of compounds, and it's certainly not tested in these microdoses. So that's a huge concern about using it. And I think just aside from all of that, the societal messages that it sends are just horrendous. It's fueling weight stigma. It's fueling body dissatisfaction, and I think that that's working against everything we're trying to do to advance the respect for people who truly have metabolic dysfunction and suffer from conditions that push their body weight to abnormal levels and things, and they having to deal with that. By having the population that is just dissatisfied with like a little tiny, like a little, a little roll on their belly or something, or just natural amounts of body fat, and then they want to try to alter that, or they think that that's not acceptable. It's just sending such a bad signal. But I think that it's not only in the women's side of the influencers. I've been seeing a lot of the male ones too, where they have somebody who's like a bodybuilder and he's trying to prepare for a competition, and he's literally saying, I need to make weight in X number of weeks. And so I'm going to, take this medicine to try to like quickly over the next 6 weeks, like lower my weight. It's like, it's crazy. And he's showing himself with no shirt and he's got all the, the muscle mass and everything. So
Well, it
it's,
just trivializes every single thing about, like, just what life is about. It's just like, you need to be skinny, you need to, all these things. It's like, just take this drug, you won't eat, you don't have to eat, and that they're using it as diet drugs. And then the other thing that really bothers me as as somebody who worked in marketing forever, it's the lies, because what they do is they show from the makers, they say from the same company as like they actually show like Eli Lilly, they'll show the product, and but they somehow have like a way of getting away with that it's not that it's not the real thing.
yeah, they hide the information that
Yeah,
it's not. They try to make it appear that
right.
it's, yeah.
And I don't like that. I
Well,
don't
and I
like
also
the
saw
lying.
I saw an ad, listen to this one. I saw one recently because they're all over the place. Like you
Mhm.
cannot go online for anything without seeing
You
these
can,
things.
even on regular TV, you can,
Yeah.
or on
But
advertised Netflix, they have it.
well, I don't know about that, but I did
Hmm.
see on just like this crazy one where a medication that's not even FDA approved yet. It's like in the pipeline. It's not, it's in trials. And they had a bottle and it has the name of it on it. And it says third party tested, which makes people think, oh, it is what it's supposed to be. It's legitimate because it's been tested. And it says something like shipped to your home. And then, and then in fine print, it says for animal research only. You know, but
Yikes.
even that, even for purchasing stuff like that for animal research and animal studies, you have to have credentials and you have to have licenses. So I don't know how that's being allowed. I mean, that's not
I don't
allowed.
either.
Companies are not allowed to just sell to like the general public things that are even meant for research. So this is where I feel like whoever the regulating agencies are, I hope they step up and get involved because but I don't know if it's too late because it's so widespread that I feel like it really will be up to people, like Jen, to just catch themselves in this and not fall for all of this stuff and just know better, and for us to get the message out there that that it's not right because it's too tempting for people who feel bad about their body
It's
image. And
really tempting.
yeah,
I mean, they're beautifully produced commercials that are really targeted to people who are like, oh, maybe I just lose like 10 pounds. I'll use it for a couple of weeks. Um, it seems easy. It's not that expensive. It's a couple $100. I mean, look, I see the temptation. I see how easy it is, and
Yeah, it's rough. What do you think, Mark? I mean,
Yeah, it's. I think part of the problem is that these drugs are so effective.
Yeah.
You know,
It's like the success is its
yeah,
own success.
and because when you look at the supplement industry, which is completely unregulated, has been making billions of dollars on weight loss for decades
Right.
now, and that stuff doesn't even work. And but I think the fact that the GLP-1s are so effective at a myriad things that it just causes a lot of people, and they're preying on the vulnerabilities of people who just want to kind of look their best, feel their best. But again, my advice is you wouldn't take any other drugs in a microdose. That
Right.
I just can't think of another example except for baby aspirin, but that's been clinically proven for certain people. But aside from that, you wouldn't just start taking a drug thinking that it would have some impact. So yeah, it's about the health. Jen, that's a great question. And if you want to check out the microdosing episode, just look back in the archive. We did a whole show on microdosing, so there's a lot more information there. So, well, this has been great. Mailbag. We got through another one. If you have questions for us, go to fatsciencepodcast.com. You can check out how to ask a question. Thanks again to our Patreon community members. You can go to patreon.com/fatsciencepodcast if you'd like to help support the show. We appreciate it very much. And thanks, everybody, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.